Thanks. I heard some clapping earlier, so certainly some encouragement maybe for this presentation, which will, kind of kick off here for the next sessions of this wonderful CAP Center event. Welcome. My name is Ryan McGrath, and I'm going to be co-presenting here today with Jayme. And if you haven't noticed, we'll have the opportunity to introduce ourselves, but if you haven't noticed, of course, with the help of my wife, I am wearing the green and gold today. So that was intended, most certainly, and it was recognized by my students earlier today. I do teach an undergraduate class on Tuesdays and Thursdays, so kind of got some looks, kind of got some comments, some whispers today by the undergraduate students, and one of them had kind of recommended, we have the Thundar mascot here at NDSU that many of you are familiar with, and kind of suggested maybe borrowing maybe the Thundar head, kind of putting it on, and maybe having Professor Thundar. So maybe I'll send an email to athletics to kind of make that suggestion. But nonetheless, we're certainly very happy to be here today to kind of speak a little bit about opportunities for older adults. Specifically, today's presentation is titled Pharmacy Partnerships for Healthy Aging and Chronic Disease, Current Initiatives and Future Opportunities in North Dakota. Before we begin, though, and get going, just some comments that there will be some mentioning of off-label use of medications during this presentation, and Jayme and I have no conflicts or disclosures to report. I hope that you take a few things away from this presentation today, but specifically, we do have some operational learning objectives. One, to describe current initiatives and opportunities for pharmacies to support the health and well-being of older adults. To describe pharmacy-led initiatives and opportunities to support individuals with chronic diseases, including persons that maybe are prescribed GLP-1 medications, and to identify future opportunities for pharmacies to engage in research and collaboration at North Dakota State University to improve health outcomes. So a little bit about me. My name is Ryan McGrath, and I'm an associate professor in the Department of Health, Nutrition, and Exercise Sciences. I also direct a lab named Healthy Aging North Dakota, which is abbreviated HAND, which is a very unique abbreviation because we do a lot of things related to maybe muscle health as it pertains to hand grip strength. So I'm also a new CAP Center scientist, which is awesome. Very happy to be engaging in that role and engaging in research devoted to pharmacy practice and improving the health and well-being of older adults. And apart from my responsibilities here at NDSU, I also have an adjunct appointment at the University of North Dakota Department of Geriatrics and kind of help out with the Dakota Geriatric Workforce Enhancement Program. Also have an appointment at the Fargo VA healthcare system, and then more so globally, an appointment with the University of South Australia. Research is many, but mainly topics devoted to aging and health for the prevention and treatment of age-related disease and disability of the musculoskeletal and neuromuscular systems. And I will pause and turn it over to my colleague, Jayme.
Hello, I'm Jayme Steig. A lot of you are probably familiar with me already, so I'll try and keep it brief. I'm a faculty member at the School of Pharmacy, and I'm very fortunate that Jeff Jacobson and his staff at South Point Pharmacy let me use the pharmacy as a practice site where I work with the staff and pharmacy students on trying to do a lot of what we've been talking about today. And implementing non-dispensing types of services in the community pharmacy setting. I'm also a CAP Center scientist, which gives me the great opportunity to work with people like Dr. McGrath on a number of different pilot projects and that at South Point. I was going to say, with this presentation that I'm just the sidekick here. So I'm Robin and he's Batman. And I can't think of a thunder analogy, though, to say you're Thunder and I'm whoever Thunder's sidekick is. But I'll turn it back to you.
No, thank you for that. And, I kind of bring up this slide, you're thinking a little bit about, I'm an exercise scientist. Kind of here presenting to pharmacists, technicians, and related personnel. But, despite maybe what might be viewed on paper as kind of like an atypical situation, it's actually, I would probably reclassify it as being probably multidisciplinary. And with multidisciplinary collaborations or cross-disciplinary collaborations presents the opportunity to have a lot of really unique ideas, a lot of really unique perspectives, a lot of opportunities to work together. And I've had great opportunities to work with other members of the CAP Center. It's a great set of personnel to work with and have the opportunities to work with pharmacists in practice to help to improve patient care and do some pretty cool things with respect to research, much of which we'll talk about today. So with a lot of teamwork and with a lot of collaboration, despite maybe what would be viewed on paper as being an atypical work situation, there's a similar theme. And that theme is trying to advance the health of the public, and specifically today with a little bit more of a focus on healthy aging. And nonetheless, we're kind of experiencing really a population demographic shift, especially as it pertains to age. So by the year 2030, approximately 20% of the American population will be an older adult. And kind of as this infographic suggests, by the year 2034, for maybe the first time ever, the number or the proportion of older adults is going to outweigh the proportion of youth. And even by the year 2060, we're projected to experience a 113% population increase in older adults. And we're experiencing this locally, we're experiencing this nationally, and likewise globally. And with that older adult population increase comes a lot of, I think, healthcare demand. Ultimately, there's going to be an urgent need for healthcare providers that are devoted to working with the older adult demographic. This can include physicians, nurses, and for example, pharmacists. And we think a bit about like reach to older adults and working with older adults, and there's going to be opportunities for healthcare infrastructure that may include maybe pharmacies, for example, that would be dedicated to working with older adults. This could include long-term care facilities, or for individuals that maybe are wanting to age in place in their homes, making sure that we have opportunities to reach older adults that would be aging in place in their homes. A lot of awareness and opportunity to present on the urgent need of working with the older adult demographic at opportunities such as this event, other related professional development entities to maybe improve maybe professional development for individuals that might be working with older adults, or even working with students. A lot of students don't necessarily have experiences in working with older adults or unaware of the urgent healthcare need for older adults, and kind of presenting awareness, education for students when they're in maybe a university setting also can have great benefit. So despite those needs, we are again experiencing a rapid increase in the older adult demographic shift. And a lot of older adults live in urban settings, but they also live in rural settings. And specific to North Dakota, the proportion of older adults that might be residing in rural settings is top 10 in the United States. And with aging, and specifically in rural areas, older adults that might be residing in rural areas may be at an elevated risk for multimorbidity, functional limitations, polypharmacy, and all of those factors and attributes would accelerate time to early all-cause mortality. And there can be some problems and explanations as to why maybe we're experiencing those factors and risk factors in a rural community. One of those factors might be access to maybe healthcare and access to maybe healthcare infrastructure. And that's driving maybe some of the problems that we're observing that would be supporting or underpinning those statistics. And then also with that, lack of access maybe comes a lack of representation in research. But the good news is that there is a fair amount of evidence to suggest that access to community pharmacies is very good. And specifically some statistics to suggest that 97% approximately of Americans live within 10 miles of a pharmacy. And the diagram that we see on the bottom here that's specific to North Dakota is an example of maybe pharmacies, community pharmacies that participated in the one program, and maybe the cities within those where those pharmacies are located. And we have great coverage throughout the state of North Dakota, reaching all the way into rural areas in western North Dakota. The green circles would help to represent a 10-mile radius, and the blue circles would represent a 30-mile radius. So community pharmacies can be an awesome opportunity to reach older adults in rural communities. In my experience in interacting with older adults and kind of working with them, older adults oftentimes really like to talk about their health, like to talk about their health care, specifically maybe have an interest in maybe the medications that they're taking. And pharmacists as medication experts, it's a great opportunity to bring older adults and pharmacists together to kind of leverage the expertise of pharmacists. So older adults trust pharmacists. They view pharmacies as sites of healthcare. They're very eager to engage with pharmacists, oftentimes in my experience, to have a conversation about their medications. And it presents a great opportunity to have a triangulation of healthcare that would kind of bring together maybe the pharmacist, the patient and maybe the physician, and kind of creating that opportunity to have clinical conversations and communications ultimately with some kind of cool things that seem to be in the works. We kind of heard a little bit about this in an earlier presentation, but medication therapy management might be a great opportunity to have conversations with an older population about their medication use, which can have a lot of benefit apart from maybe identifying maybe some problems within the medications, but also thinking a little bit about lowering costs or maybe trying to prevent adverse health events that might be related to those medications. It could be very beneficial. And with the rapidly growing older adult demographic, we're going to probably start to see an increase in maybe some age-related health conditions. And the diagram that you see on the left would be specific to Alzheimer's disease and Alzheimer's disease-related dementias, which tends to be a very high-level public health concern, especially within the National Institute of Aging, being a priority. And we're kind of seeing that maybe by the year 2060, approximately 15% of the population might be living with Alzheimer's dementia, which is in alignment with the 113% increase in older adults that we're projected to experience by the year 2030. And then similarly to the diagram that would be on the right would help to be representative of chronic conditions that may include maybe diabetes or hyperlipidemia or problems related to cardiovascular health, for example. And older adults are living with one condition, several of them, over 90%. And then when examining multimorbidity, with older adults having 2 or more chronic conditions, we're probably looking at trends consistently being above the 75% mark. With chronic conditions, kind of considering the role of polypharmacy, and we're kind of seeing some trajectories kind of go upward with respect to polypharmacy, not just in the population, which is outlined on the diagram on the left, such that a very large proportion of persons might be with polypharmacy. But when examining the stratified trends, you'll notice that the diagram that's on the right, and specifically the orange lines, we're seeing an upward population increase for the older adult demographic. And approximately the latest statistics, according to this diagram, would indicate that almost 50% of older adults are engaging in polypharmacy. So when considering chronic conditions, considering polypharmacy, we think a bit about the role of potentially inappropriate medications. And potentially inappropriate medications might be specifically medications that would present an elevated risk for an adverse event or a problem with interactions in an older adult demographic. Kind of seen some trends in increasing, kind of consistent with what we're seeing with the increase in the older adult demographic. Likewise with polypharmacy, but we're seeing and observing maybe the prevalence of potentially inappropriate medications kind of go upward to a very high level. And there's a lot of tools that do exist for helping to identify potentially inappropriate medications. One of those tools does include the Beers criteria, which comes from the American Geriatric Society. But when I think utilizing the Beers criteria from the American Geriatric Society, we're seeing some risk factors that do present themselves for potentially inappropriate medications. And again, those risk factors may include living in a rural area, older adult, multimorbidity, polypharmacy. So we're starting to kind of see some themes emerge. I was fortunate to engage in a pilot level investigation that was led by Elizabeth Skoy and colleagues when looking to implement maybe Beers criteria for medication therapy management for identifying potentially inappropriate medications. And we found some, in my opinion, striking findings with these pilot data. These pilot data are published in the Journal of the American Geriatric Society, but approximately of those that were screened, 88% are utilizing a potentially inappropriate medication. And while there's differences in the risk stratification with respect to the potentially inappropriate medications that may kind of vary from providing education to considering the risk-benefit analysis, but also kind of ranging into possible T-prescription and kind of reaching out to a physician or prescribing physician to kind of have a conversation about what that might mean for the patient. And also kind of including the Beers criteria in some of these community pharmacies. We also saw good feasibility such that we saw value from patients, we saw value from the pharmacists. There can be effective training strategies that we can, I think, refine before kind of including these lists at a more widespread level. So there's exciting promise in working with the Beers criteria to help to identify potentially inappropriate medications in community pharmacies. Also, we had a little bit of a conversation in an earlier presentation about the role of GLP-1s. And I included, I just had to take a picture of this Because as an exercise scientist, I'm thinking a little bit about like, okay, the prevention and treatment of maybe chronic conditions and obesity. And I think a bit about like, okay, physical activity participation or nutrition counseling. But I saw the GLP-1 journey and it just kind of struck me because it's kind of maybe a symbol of maybe where we are as a society with the inclusion and the popularity of GLP-1s. And I've certainly seen advertisements in the popular press or just commercials for GLP-1s. So we're kind of seeing it now with shopping for groceries. So interesting to see that. But, maybe as to maybe why we are here, thinking a little bit about the role of physical activity participation. And the diagram on the left side would be indicative of persons that are meeting the physical activity guidelines for Americans, which is engaging in greater than or equal to 150 minutes of moderate to vigorous physical activity a week, or maybe like engaging in resistance training a couple of times a week with the major muscle groups. And a very large proportion of Americans are not meeting those guidelines. Approximately 46 are in the ballpark of about half. And specifically, there are some statistics to suggest that adults during waking hours are sedentary for 9.5 hours a day. So very high level of sedentary behavior. And that would be supporting then the evidence that we're seeing on the right, such that we're seeing the prevalence of obesity as defined by a body mass index of greater than or equal to 30 kilograms per meter squared. And with those criteria, we're seeing about 40% of the population living with obesity. And if we even kind of examine that a little bit more closely with respect to age demographics, middle age and older adults, there's certainly a strong signal for obesity prevalence that is existing there. So GLP-1s have most certainly come on the scene. They have shown promise, kind of the evidence that I have read and reviewed for reducing maybe body weight, body mass, and their popularity has certainly increased for a variety of reasons. There are some evidence to suggest that we're experiencing maybe a 700% increase in use, including for cosmetic and off-label purposes. But the diagram that's located here, figure 1 on the lower right corner, kind of provides some insights as to maybe the persons that might be taking a GLP-1 medication. And when kind of considering the age demographic too, the middle age, the older adult demographic, we're certainly seeing a high proportion of persons that might be taking a GLP-1 medication with respect to maybe a middle age and older adult demographic. And there can be benefit that we're observing, or certainly a signal of benefit for maybe reduction in body weight, but with that comes maybe some changes in body composition, kind of considering maybe the risk-benefit analysis of working with GLP-1s. While we might be seeing some reductions in body weight, what is the body composition that's changing exactly? What does this mean for like factors related to muscle health? So with maybe some of the challenges that may exist with some of the risk factors that we're kind of starting to see emerge with GLP-1 use, the reduction that we're observing in maybe body weight could certainly be attributable to maybe reductions in muscle mass. And muscle mass is important for health. It tends to be a very metabolic tissue that helps to regulate metabolism and certainly would have relevance for maybe the prevention and treatment of obesity, not just in the present, but also in the future. So if GLP-1s potentially are reducing muscle mass, that could be problematic in order for maybe the restoration of strength at a later time, or potentially elevating the risk for a muscle-specific health condition. And a muscle-specific health condition could be something called sarcopenia. And sarcopenia tends to be a muscle condition that would be observable for reductions in muscle mass and strength. This could also be characterized as sarcopenic obesity, so kind of implementing the role of fat mass, and we're seeing some age-related changes, an increase in fat mass and a decrease in muscle mass. And we can even include bone, because muscle and bone are oftentimes related. So we could certainly have the presence of osteosarcopenic obesity when considering maybe osteoporosis, low muscle mass, and high levels of fat mass. And the presence of sarcopenia and sarcopenic obesity, it tends to be related with a lot of bad stuff as a whole, and some of that bad stuff may include problems with mobility, falls, fractures related to falls, maybe some problems with basic self-care. It can be a very problematic situation, and a situation that maybe needs to be observed a little bit more closely. What we're seeing on the right side is an example of maybe some normative data or some population-based data for looking at different trajectories and curves for muscle strength. And we're certainly seeing like an age-related trend that does exist. Oftentimes what does happen is that maybe at around age 30 or in the 30s, muscle mass and strength tends to peak, and then we kind of experience at a slow level at first, maybe some age-related declines, and then those age-related declines tend to exacerbate into older adulthood. And there can be some differences between being in the 90th percentile and maybe being in the 10th percentile, for example. And those differences could be observed on the image on the right, which tends to be a curve that is associated with muscle mass and strength and how that does change over time as age kind of continues to increase. And we see two examples. The person that might be on the higher trajectory might be an example of a person that is engaging in healthy lifestyle behaviors early in life. That could include like physical activity participation, maybe other healthy lifestyle behaviors, and then their time to maybe a functional limitation or their time to maybe an age-related chronic condition is a little bit more decelerated, whereas an individual that maybe has not been engaging in healthy lifestyle behaviors, they have a lower peak threshold for their muscle mass and strength at about age 30. And then their time to maybe a functional limitation or an age-related condition could be a little bit more accelerated relative to the individual that maybe is experiencing higher levels of muscle mass and strength. So there could be some differences that do exist between being in the 90th percentile versus being in the 5th percentile for muscle mass and strength. And how does GLP-1s kind of, I think, change those trajectories? Or, you know, are we putting individuals that might be at risk if they're experiencing deteriorations in their muscle health? Is that going to exacerbate or change maybe their muscle curve as they age, which could put them at risk for a lot of really bad stuff? So kind of, I think, you know, taking a look at this in community pharmacies, because something that could certainly be done, especially as we're seeing a rapid increase in GLP-1 use. Examining muscle health can be relatively feasible to do in community pharmacies. One of the first levels is looking at muscle strength, and muscle strength can be feasibly and reliably assessed with a tool called hand grip strength. This is a hand grip dynamometer, relatively inexpensive. It runs on a sustainable energy source, easy to work with, easy to administer. I would say that like having a conversation with a patient about their muscle strength and their muscle health is really engaging because a lot of persons kind of understand the role of muscle strength. So something that could certainly be done there. Looking at muscle mass, that can be done with a variety of tools too. That may include just like a handheld bioelectrical impedance, for example, or even just looking at mobility and just kind of getting up and down from a chair, walking across a small room, kind of timing how long it may take to complete some of those tasks. And this would be a good example of kind of, I think, working with tools to help to determine the presence or absence of sarcopenia. And it's kind of unique to work with like hand grip strength. And this is a great opportunity to maybe present how like tools that are oftentimes used in research, for example, might get stuck in research land oftentimes and may become unknown to persons that are working directly with maybe older adults. And having the opportunity to kind of pull some of these tools and methods that have demonstrated a lot of promise for improving health and kind of for screening could be really beneficial for, I think, pulling that research into practice. Also examined, you know, just the other day, the role of disability-adjusted life years, which comes from the global burden of disease. It's a very large analysis that oftentimes is conducted and published in a variety of journals, including The Lancet, for example. And, you know, kind of was looking at differences in disability-adjusted life years as they pertain to certain health conditions, and certainly saw, you know, cardiovascular health, muscle health, and cognitive health, all within kind of like the top category of disability adjusted years classifications. And we're certainly seeing this, it's very relevant in terms of age-related health conditions, and being able to screen for maybe factors related to heart health, muscle health, and cognitive health could have great relevance for an older adult demographic, and helps to, again, establish that triangulation between the pharmacist, the patient, and the primary healthcare provider, for example. And pulling in some of these feasible tools and working with older adults does kind of, I think, tend to be a little bit engaging for the older adult demographic. And these are some preliminary data that we all just got done running from a pilot investigation that we're probably looking toward publishing. And kind of within the 106 older adults that we did screen, we certainly saw a signal tool for the detection of arrhythmia, the detection of weakness, and then similarly the detection of cognitive impairment, and certainly offered some education and presented the opportunity to maybe have referral to a primary healthcare provider to look at this stuff a little bit more closely. And we saw roughly 1 in 4 of our older adult sample kind of went and visited their primary care provider as a result of these screenings. So certainly some promise there for helping to support those communications and to prevent some awesome opportunities to screen for some age-related health conditions in a pharmacy. So I'm going to pause for a moment and I'm going to kind of turn it over to Jayme for maybe some perspectives from the pharmacist.
Yeah, thank you. At South Point, we've had the opportunity to work with Dr. McGrath and his team now we're on our 3rd project actually now. So it's been a good partnership. We started out with the potentially inappropriate medications project that he discussed. And what was great about that is that it's something that we could just incorporate into the things that we were already doing. So if we're doing a CMR, an outcome CMR for someone, this project provided us with some really good tools that, at least from my perspective, helped me do a better job in performing the CMR, in looking for potentially inappropriate medications, having those discussions with my patients. I still apply that principle and those tools and that knowledge in the CMRs that we're currently providing, in my counseling of older adults as well, especially looking at those anticholinergic medications and those other common drug classes that are on the BEERS list. The other 2 projects with the hand lab involve the research that is on the screen there. With older adults, it's fun working with older adults because they're receptive to these types of things. It can be challenging sometimes to discuss with a 27-year-old why they should participate in some of our services. But when I'm asking someone who's got extra time and that, they're very open to these types of screenings. And these are not lengthy screenings. We can, with this project here, we could complete a screening in about 10 to 15 minutes. With the current project that we're doing involving the people on GLP-1s, we're looking more at like a 15 to 20-minute screening. So it's not a huge time commitment on their part. The other thing that's great about these projects is there's a toy that people get to play with. I'm sure that makes people interested. It's like at the fair where you have the sledgehammer to see your strength. That's kind of how some people treat the dynamometer. But it's seriously that does help with participation, in that you have these tools for them to interact with rather than a checklist, which is something that we probably see more commonly done. And so it's also been valuable to get the feedback from the participants as far as the value of the screenings. They do find value in them. Some people are familiar with the screenings that we do, and some people are like, I've never done this before. And it's really helped them understand and lead to conversations related not just to their medications, but to their lifestyle and other factors as well that can support healthy aging. And so we've had a good experience incorporating these research projects now into our practice, and look forward to working with Dr. McGrath and others to expand those to other settings, other pharmacies, and to continue to add look for additional research opportunities.
Okay, great. Thank you for that commentary. And as a new CAP Center scientist, I mean, I've kind of been presented with, new ideas, new opportunities. And as I continue to learn and grow, I do want to suggest that working with the CAP Center is a great thing. It provides a lot of wonderful resources, including education, opportunities to improve patient care, opportunities to engage in research to help to springboard maybe new opportunities within community pharmacies and related. So it's been a wonderful experience. And as I continue to learn and grow more, I am excited about the opportunity to continue, because I do think, if North Dakota isn't already a leader in pharmacy practice, I genuinely do believe that North Dakota can be a leader in pharmacy practice after kind of the experiences that I do have here. So I hope that my enthusiasm and excitement does resonate with all of you here today. So, that reaches the end of our presentation, and Jayme and I are happy to answer any questions that you might have now. Yeah, question. I'm probably going to look over to my left and maybe ask Jayme about that one as the pharmacist with respect to maybe billing.
Yes and no. There are some avenues, like with the PIM project and looking for potentially inappropriate medications. Again, to me, I was able to use that to make my CMRs more efficient and effective. So it's not necessarily a new billing opportunity, but it helps do a better job with that existing opportunity that exists. I don't know if that kind of addresses things there. With some of these other screenings, at this time, there's not a code for sarcopenia screening that I'm aware of, for that pharmacist can bill. But participating in research grants, there is funding that comes to the pharmacy to help with staff training and support and to compensate for the pharmacy's time that goes into it. And the idea is that if we can establish the value in some of these services through these projects, that might be an avenue, to have some billing opportunities in the future.
Well, if there are other questions that emerge, you can certainly speak with Jayme and I after the presentation, or if you kind of want to have fun with our dynamometer, we can maybe have like a hand grip strength competition too. So that's there, and our emails are listed there if you want to have follow-up. You can kind of take an image of that, and certainly happy to respond to any inquiries that you may have later. But nonetheless, we'll kind of maybe have maybe some virtual breakout for those that might be online, and maybe kind of pivot toward maybe some of the questions for roundtable discussions that might be at your tables or might be observable here on the projector. And then maybe after a bit of time and discussion, we'll reconvene for maybe that additional slide that might be of interest. So we'll take a moment here to stop and have some conversation.